I am the National Community Health Representative Consultant and the Community Health Team Lead for the Indian Health Service. And I am an enrolled member of the Lone Pine Paiute Shoshone Tribe, and it is my pleasure to welcome you to the first of 2 town halls in partnership with the Indian Health Service and the Johns Hopkins Center for American Indian Health. This collaboration brings together unique and specialized knowledge from the fields of research, medicine, and academia into the world of healthcare and communities across Indian country. Today's presentation is a 2-part virtual town hall series that serves as a forum for community-based health workers, who are our CHRs, health educators, public health nurses, and health promoters working on the front line in Native communities to learn best practices in addressing outreach, education, and prevention during this time of the new coronavirus. Today's town hall has 2 presenters, Dr. Laura Hammett and Dr. Jill Moses. Dr. Hammett is Director of Infectious Disease Programs at the Center for American Indian Health and an Associate Professor at the Johns Hopkins Bloomberg School of Public Health. Her research focus is the epidemiology and prevention of pediatric infectious diseases, with a particular interest in the ecology of the human microbiome as it relates to treatment and prevention of disease. Dr. Moses is a board-certified pediatrician and the Director of Public Health with the Chinle Service Unit with the Navajo Area Indian Health Service. She graduated from Vanderbilt Medical School and completed her residency in pediatrics and preventive medicine. We also have IHS national consultants as part of a panel team to answer questions during the Q&A sessions, and today's panel team will consist of Alberta Vicente, the National Health Promotion Disease Prevention Consultant, Tina Taw, the Public Health Nursing Consultant, and myself as the National CHR Consultant. So with that, I would like to say thank you to all the participants on the call, our presenters, our panel team members, and the exceptional people behind the scenes who have contributed in making this town hall happen. So thank you.
Thank you, Michelle, for that great introduction, and welcome everybody. We're delighted to be here to spend some time together to talk about coronavirus and the incredibly important role that community-facing workers play, not only in normal times with increasing access to health services and products within communities, communicating health concepts, reducing the burdens felt by the formal healthcare systems. All of that happens on a day-to-day basis already, and those efforts are even more important and critical during the time of a pandemic, where community-facing health workers act as community educators, mobilizers, contribute to surveillance systems, and fill gaps in health services. You are all trusted voices in the community and really incredible assets for the pandemic response. So I want to start us off today by just talking about as Michelle mentioned, we're joined by Dr. Jill Moses and the 3 panelists that are shown here, who will be available to add to the discussion today and to help answer questions that may come up. We're going to start off by just talking about a brief overview of coronavirus, understanding the case counts, the symptoms, the risk factors, and preventive measures. And then we want to highlight the community-based responses, including the CHR and HPDP activities, the important role that community-based health workers have in pandemic response, and the really key importance of communication as we move forward with the response to COVID-19. And then we'll also provide some key information on resources. I do want to preface this by saying that this is the first in a 2-part series. So as you can see, what we have here for the objectives for this talk, there'll be another talk at this same time next week that will talk a little bit more specifically about community health worker roles and as well as environmental health response, mental health, and some other aspects of the response. So I just wanted to flag that for you, that this will be part one of a two-part series. And so with that, we'll start with a general overview of coronavirus. I'm sure everyone on the line has learned more about this virus than you ever thought possible in the course of the past month or so. Coronavirus is a large family of viruses that cause illnesses in both animals and humans. It's a very common cause of respiratory infections, ranging from the common cold, which we have 4 coronavirus strains that circulate routinely in the United States and cause usually fairly mild illnesses like colds, but can cause pneumonia-like illness. Coronavirus is also the cause of the SARS-1 epidemic that occurred back in the early 2000s. So this novel coronavirus that we're talking about today was first documented in December 2019. It's called SARS coronavirus 2, and it causes a disease known as coronavirus 2019 or COVID-19, which is distinct from the illness that was caused by the SARS-1 coronavirus back in 2003. Globally, these case counts have been updated as of this morning on the Hopkins COVID dashboard. You can see that we're over 2.5 million confirmed cases. This has spread globally throughout the world at this point, with the largest number of cases now being reported in the United States. And if we look at our more population-specific data on the next slide, you can see COVID-19 cases in Indian country. This is from the IHS website, which is updated on a daily basis at the website that's shown there. You can see in each of the IHS areas the number that have been tested, the number that are positive, and the number that are negative. And you can see all areas of Indian country have been affected by COVID-19 disease, with the largest number of cases far and away having been reported in the Southwest on Navajo Nation. Specific Navajo Nation data shown on the right-hand side of the slide, where you can see the case counts as of last night, 1,206 cases, with disease now having been identified in really all parts of Navajo Nation. After initially starting in the western part, we can see that cases are occurring throughout Navajo Nation now. So we know that COVID-19 is a respiratory virus. It is spread primarily by respiratory droplets. And this is via infected droplets landing on people or on objects or on surfaces, and then those being transmitted. So you can see in the graphic there, if you're close to somebody who is infected, those droplets can transmit directly to people who are close by, but those droplets can also land on countertops, tables, phones, other surfaces that we then may touch and get the infected droplets and get the virus on our hands, and then we can inoculate ourselves by then touching our hands to our eyes, our nose, or our mouth. So the guidance really around prevention of transmission or slowing the spread of disease is based on what we know about how it is spread, based on the fact that it is being spread by respiratory droplets. So we have guidance on the right-hand side that really focuses on this aspect of physical distancing and keeping more than 6 feet apart from people. It's not like there is a wall at 6 feet where the virus cannot travel any further than that, but most of these droplets are fairly large and heavy droplets that don't float around in the air for longer distances than that. Certainly if you're near somebody who's coughing or sneezing and having sort of forceful expulsion of droplets, that they can travel further. But for the most part, we're trying to encourage people to maintain that minimum of 6 feet distance from others to help slow the spread. Critically important as well is staying home when you're sick, even if the illness is mild. I think a lot of us have been used to just, powering through when we're not feeling well and going out and taking care of our responsibilities. But in this case, it's particularly important for people, even with the most minimal of symptoms, to be staying at home and slowing the spread of that virus to others. basic cough and sneeze etiquette is important to cover the cough and the sneeze into the elbow or to the shoulder or into a tissue that then is immediately disposed, followed by hand washing. Because of the fact that the virus is transmitted through respiratory droplets that we expel even through basic speaking activities, even if we're not actively coughing or sneezing, these droplets can land on surfaces. And so it's really important to clean and disinfect those surfaces, both flat surfaces that droplets can land on, as well as other surfaces that are high touch surfaces that we may pick up droplets on our hands and then open door handles or touch phones, and those surfaces need to be disinfected frequently. We also really have to go back to basics here and remember the critical importance of washing our hands frequently, ideally with soap and water, or if that's not available, with an alcohol-based hand rub for 20 seconds. The virus gets broken apart by the soap molecules and washed away, and so this is a very effective way of actually removing any virus particles from your hands. It's just the basic act of soap and water and rubbing the virus and washing the virus off of your hands with that friction action. And then, of course, avoiding touching eyes, mouth, and nose as much as possible in case we do have virus that's on our hands. We can help prevent ourselves from spreading it or inoculating ourselves by not touching eyes, nose, or mouth. The symptoms of COVID-19, initially, I think we had a very strong impression that this was primarily fever and cough illness that could be also complicated by more severe breathing difficulties. But now I think we've come to appreciate that there are a wide variety of symptoms that have been reported, from mild illness that can include a sore throat or runny nose, what we would think of as just sort of mild cold-like symptoms. But we also have reports of gastrointestinal symptoms as well, and many people report tiredness. More severe cases are characterized by higher fever and more breathing difficulties that can include severe infection of the lungs or pneumonia. And really highlighting here that the most important danger sign is really difficulty breathing. We do know that oftentimes the illness does not become severe until the second or third week of illness. And an important learning in the past month or so has been the extent of asymptomatic infection. So we now know that as many as 25 to up to 50% of people will have the COVID-19 infection but don't have any symptoms at all. This is important for how we think about slowing the spread because it's possible for people who are asymptomatic to be transmitting the virus. And so that reinforces the importance of these social distancing measures that have been put in place. The average time between being exposed and catching the virus and then developing symptoms is about 5 days, but it ranges from 1 to 14 days. People are at highest risk for more severe outcomes for COVID-19 if they're older, and we generally define that as 60 to 65 and older, although in some populations where there are higher underlying conditions in younger age groups, then younger people can be at higher risk as well. People with underlying medical problems, including high blood pressure, heart disease, lung problems, and diabetes are at higher risk for more severe COVID-19 infections. And so we really want to try to help elders and people at high risk to be able to stay at home and to be sheltered from ill people. And I want to emphasize that we have to be clear in our communications that just because you don't fall into a high-risk category doesn't mean you have no risk. So really making sure that when we're talking to people in the community, we can make sure they understand that low risk doesn't mean no risk of disease. And it certainly doesn't mean that we couldn't become asymptomatically infected and pose a risk to others who are at higher risk. Testing for COVID-19 is typically performed by healthcare personnel by collecting a nasopharyngeal swab from the back of the nose or throat, or alternatively, we can use mid-turbinate swabs that don't go quite as far back. as a nasopharyngeal swab, and throat swabs have also been used. It's important, obviously, for personnel to be wearing appropriate personal protective equipment during swab collection so that we minimize any risk of unintentional transmission. I'm sure everybody's aware that there have been challenges in getting adequate testing up and running in this country and in many parts of the world. This is getting better, but we are still at a point where expanded testing in most communities would still be beneficial. Expanded testing will help us in a number of ways. It will help us to know the full number of cases. Right now, we don't know the full number of cases, and that makes it difficult to understand the severity among the different age groups and risk groups, as well as how far and wide the virus has spread. Expanded testing can also help us to identify cases and therefore put in place appropriate case management strategies like isolation and quarantine of their close contacts. We touched on this earlier, but there's a question, of course, early on about whether you could catch COVID-19 from somebody that didn't have any symptoms. And I think what we now know is that the answer to this is yes. There are many people experience only mild symptoms or have no symptoms at all. We still think that the main way that disease is spread is from respiratory droplets from someone who is actively coughing. That's clearly and obviously a much more efficient way for respiratory droplets to be spread. Is through that mechanism, but we do now understand that people can still transmit the infection even if they themselves have no symptoms. So again, reinforcing that idea that we need to be maintaining at least a 6-foot distance from other people, that we should really be avoiding large gatherings or groups of people, doing our necessary errands at off hours to try and minimize exposures as much as possible, and really avoiding all non-essential travel, shopping, and social visits. There's been some research happening to help us understand better about how long the virus survives on surfaces. And we now know that it can be, in some cases, a few hours or up to several days. It really depends on the type of surface, the temperature, the humidity of the environment, and other factors. And the best advice is that if you think a surface can possibly be contaminated, to clean it with disinfectant and then wash or clean your hands after that. Especially important, as we mentioned earlier, to keep those high-touch surfaces and flat surfaces cleaned at least daily, and more often depending on the circumstance. This graphic shows information from a study that was published in the New England Journal last month on looking at how long the virus can survive on various surfaces, and you can see the estimates there. For various different surfaces, with cardboard lasting even sometimes up to 24 hours, stainless steel 2 to 3 days, plastic 2 to 3 days. So just a good reminder that just because you enter a room or a space and you don't see anybody who's sick in that area, it's certainly possible that these infectious respiratory droplets can be on surfaces. And so just really being mindful about what our hands are touching and what we're coming in contact with. There are no medications or vaccines proven to prevent or treat COVID-19 at this time, although, as I'm sure everyone is aware, there are many clinical trials that have been done right now or that are underway. Right now, our main treatment regimens are symptomatic relief, providing oxygen therapy and treating people's symptoms, but hopefully we will have vaccines, antivirals, or monoclonal antibodies that will be available. The vaccines, as many people will know, typically take many years to develop. And so we're fortunate in this case that there are different vaccine platforms that have been in development, and that people have been thinking about coronaviruses because of SARS and MERS for a little while, that we're in a position now to potentially expect to have a vaccine available for more widespread testing and potential deployment within 12 to 18 months, but that's still quite a ways out. We should have data hopefully sooner than that on some of the antiviral medications or on monoclonal antibodies, and some people will have also heard about a convalescent plasma option where we can use plasma, which contains antibodies from people who have recovered from the COVID-19 infection, and administer those to people who have been either exposed or who have COVID-19 disease to try and fight off the infection. The website that was shown there on the right-hand side of that slide is a good resource to stay up to date on all of the different treatment and vaccines in the research pipeline. And so I touched on this already about how quickly a vaccine or antiviral could be available. They usually take, as I mentioned, quite a long time to develop from the initial phase 1 safety trials to licensure. But now we expect to potentially have vaccines available for 12 to 18 months, with antivirals potentially being available sooner, depending on how these ongoing clinical trials, what these ongoing clinical trials show. You've heard probably a lot of talk recently, obviously, about social distancing, and we've mentioned that, as well as isolation and quarantine. And I just want to spend a minute defining those different terms, because I think they are important public health concepts that do have different meanings, and we want to try and communicate about them accurately and correctly. So social distancing, I think, as people know, is really trying to avoid contact with large groups of people and maintain a physical distance of at least 6 feet when you are in public places or around other people. This is really critical for reducing the spread of the virus. Isolation is what happens when a person is known to be infected with COVID-19. Then we isolate them to prevent them from spreading it to other people in their households generally, or it could be in a clinical setting where they're isolated from other people in a clinical setting who don't have COVID illness. And then quarantine is different. That's a term that we use for people who are exposed to COVID, but do not themselves actually have disease or are not yet symptomatic. So we separate those individuals and ask them to self-quarantine generally in case they are incubating the virus and in case they are becoming sick and in a pre-symptomatic phase where they could still be potentially infected and transmitting that. So if people have been exposed to someone in a way that constitutes a substantial risk of having acquired the infection, they're asked to quarantine for 14 days to pass through that range of incubation period that I mentioned earlier, to make sure that they don't themselves develop illness or aren't potentially infected and at risk of transmitting that to others. So those are those 3 different terms. CDC guidance, as I'm sure everyone is aware, has recently changed to recommend that face masks can be an appropriate way to slow the spread of this virus and should be used in public places. So there are 3 different types of masks that I want to mention here. The pictures that are shown on the right are of hand-sewn masks that can be used by individuals who are in public spaces. They can be used by individuals who are caring for COVID-19 infected patients at home, as well as by people who do have COVID-19 infection at home. If surgical masks are not available and if they can't isolate in the household and they are, at risk of transmitting to other people, these can help slow the spread. And this is really about not protecting the mask wearer as much as it is about protecting the other people in the community who are at risk. So my wearing a mask protects you, and your wearing a mask protects me. Surgical masks are also available and can be used by patients who are infected by COVID-19 if they're around other people, and used for healthcare workers for activities unless a more high-level mask, an N95 respirator mask is required. I do want to emphasize that surgical masks right now should really be prioritized for healthcare settings, and I think we want to be sending this message out to everybody that we're communicating with as well, that we, even though this recommendation for wearing a mask has been put in place, we don't want that to create a run on supplies and be taking away critical supplies from healthcare settings where they are needed most. And then N95 masks are used by healthcare workers who are taking care of COVID-19 patients and who are performing aerosolizing procedures that put them at greater risk for exposure and potential transmission. And speaking further to this concept of slowing the spread and what social distancing aims to accomplish, you can see in this graph, we know that in sort of standard conditions, one infected person with coronavirus can spread to an average of can spread the infection to an average of 2.5 more people over that course of an average, incubation of about 5 days. And then of those 2.5 people each spread to 2.5 people more, you can see that over a course of a month, one infection actually leads to 406 infected people. If you reduce that exposure by 50%, and that infected person is not around as many people, or around half as many people, then they will only spread that infection and infect 1.25 people, which that 1.25 persons then goes on to infect other people. And after that period of 30 days, if you have 50% less exposure, you can see that there are only 15 people infected. So this is really just trying to illustrate that power of social distancing. If you have further reductions in the amount of exposure, you can see that even fewer people are infected. So really trying to highlight the critical importance of reducing social contact as a way to reduce the spread of this virus. Many people have heard, on the next slide, you'll see a graph showing what it means to flatten the curve. And I think a lot of people have heard a lot more about this in the past month than ever before. But the ideal goal in fighting any pandemic is to completely halt the spread, but merely slowing it or mitigating the spread is really critical, because it reduces the number of cases that are active at any given time. And so what you see in this graph is the number of cases on the y-axis and time on the x-axis. And without protective measures and social distancing in place, you can see a very sharp peak in the number of cases that actually exceeds the healthcare system capacity, which is shown there in the dotted line. And what we're trying to achieve with the social distancing is slowing the number of cases that are occurring all at once, which gives doctors, hospitals, police, vaccine manufacturers time to prepare and respond without those systems becoming overwhelmed. So a low curve shows that the virus is spreading slower, fewer people are diagnosed with the disease on any given day, and it prevents overtaxing the healthcare system. I'm going to turn it over to Dr. Jill Moses now, who will take us through the rest of these slides.
Hi, thanks, Laura. So in this slide, it outlines some differences between influenza or the flu and allergies and the COVID-19 infection. And fortunately, although at the beginning of the outbreak, there were still quite a few influenza cases out there, that isn't true right now. And so it makes it a little less confusing. But if you look at influenza, so that's something many people have experienced, where there's fever, cough, sore throat, body aches, fatigue. It lasts 3 to 7 days. There's a vaccine that can help prevent it. There's an antiviral medication, Tamiflu, that can be helpful if given early. And generally, we see the people who tend to get hospitalized with flu infections the most are the very young and the old. So it's seasonal, and the case fatality rate is 0.1%. Everybody's probably familiar with allergy symptoms. It's sneezing and itchy eyes and runny nose, and that being seasonal as well. And then the problem is that COVID-19, as Laura said earlier, although in the beginning, I think people focus very much on fever, cough, and shortness of breath. And that is true that for many people, those can be symptoms, but not for everybody all the time. And that we know that it's the presentation can be quite tricky. And so from people like in Chinley Service Unit, when we have a positive test, I'm often the person who calls that patient and lets them know about their positive test result. And I talk to them about what kind of symptoms they're experiencing at that moment and what symptoms they've experienced over time. And I've been struck by the wide variation in presentation, all the way from people saying, I didn't have any symptoms, to I thought I had allergies. That's why I didn't go get tested right away. Or, you know, to people who are very clearly, you know, quite ill with the symptoms. So you think about the fever and cough and shortness of breath. And so, you know, the symptoms vary quite a bit over time. We said that seeing more, sometimes worsening symptoms in the second and third week. And that, you know, as Laura said before, that we don't have a vaccine or really effective medication right now. And we're not seeing much severe disease in the young. In this case, it's really hits the elderly and those with underlying chronic conditions more. And we don't know yet what's going to happen with seasonality. And we don't know. We have some ideas about case fatality being about 10 times more deadly than flu, but that getting really firm figures on that, I think, is still to come. So if you go to the next slide. So we're going to just shift gears here and talk about the IHS response to COVID-19. I think that everybody is aware that across the Indian health system, that hospitals and clinics have been kind of redesigning how they're providing care to assure that to reduce having people come into clinics and potentially for elective things, things that can be delayed, and to prevent risk of exposure and to gear up to be able to meet the demand, the anticipated demand for more healthcare services. So that work is definitely happening. But on the public health side, there are a number of departments and programs within the Indian health system that are kind of taking their usual public health work and shifting it to meet the demands of the COVID-19 response. So community health representatives who normally provide healthcare, health promotion, disease prevention services, and help with community-oriented primary care services. You know, that they are like great advocates in the community to help bridge be a bridge between people in the community and the healthcare system, and provide health education, and are very helpful in reducing hospital readmissions. You know, that normal work of CHRs is then now being shifted in many areas to help fill in some gaps or in additional needs that families are having in the COVID-19 situation. And so, for example, on Navajo, the CHRs are now also assisting with getting essential, you know, basic supplies to families that are under prolonged isolation or quarantine, and helping patients that are high risk that they track out in the community. I'll go back one slide. Helping them get their medication refills and other things, so that to help protect those high risk patients from having to go into the clinic unnecessarily. Health promotion and disease prevention has also been critical in this response. So they, you know, their normal work is working on prevention at different levels, and social marketing and community education and many different health promotion strategies. Those skills have really been essential in helping get the message out about what people need to do to protect themselves and their families in this in the COVID-19 in this pandemic. You can go to the next slide. And then public health nursing has, you know, public health nurses have been prepared RNs. They provide population-based care to communities, and with home visits and work with high-risk populations. They do some case management in coordination with primary care. They serve as extensions and support transitioning healthcare into the community. And they work at, at the level of primary, secondary, and tertiary prevention, doing a whole host of activities in that way. And on Navajo, and I suspect in many parts of the country, public health nursing has really shifted their focus in this response to being the mainstay in coordination with CHRs in the effort to do contact tracing and case management of those that are positive with COVID-19, and really being like working in that epi response. So public health nurses and CHRs and environmental health, are part of epi response teams and responding to communicable diseases all over. But this, the workload for epi response has become like the main thing that they're doing now with the pandemic. And then they're trying to, keep up those essential other services with high-risk patients, referrals, in addition to that. So next slide. So the role of community-based health workers is to, understand the disease and stay current with recommendations, for communication, like listening to concerns in the community, issues that are coming up, providing education, for practicing cultural competency, dispelling myths, with service coordination, helping link people to local resources. They're doing wellness checks for people who are isolated or quarantined or high risk and need to shelter in place, where they ask for, about the need for medication refills, how they're doing with their chronic conditions, their mental health, food, water, coal, wood, livestock, and then really empowering individuals and families to take care of themselves. Next slide. So some messaging, key messaging for everyone to be comfortable delivering to your friends and family and coworkers is that, the importance of hand washing and physical distancing, that anyone who is sick, you heard how the wide range of symptoms that people can have. So if somebody's sick, it's really important that they isolate from other people, not go to work, not go out until they, the testing, sometimes even a negative test doesn't tell you, like the test, there can be false negatives. And so really anyone who's sick with any kind of respiratory symptoms needs to stay away from other people to avoid infecting them, whether or not their test result is positive or negative. And that many people with COVID-19 have very mild symptoms, and so may feel like it's okay to go to work. There was a time where people would go to work with mild respiratory symptoms, and that was okay. It's not okay anymore. It's really important to protect others to stay at home. So that stay home, to protect your family and to protect others. You can go to the next slide. And here's some great messaging that's out there that could be shared to post out in your communities, that social distancing saves lives, and staying, that I love the picture of the care. Everybody, I think, across the system has gone to doing a lot of their work by phone, which doesn't make as good a picture, but also, now we're expanding some telehealth capabilities in new and different ways. And that's going to be, I think, a big part of our way of managing this pandemic going forward and getting things under control. So next slide. And then here's some resources. Laura, did you want to add anything else?
Thanks so much, Jill. Can you hear me?
Yes.
Okay, great. I keep getting a message that I can't unmute myself, but Looks like it worked, so thank you. I think we can go on to the next slide perhaps, and then just really to acknowledge the people that we've been working most directly with and who are featured in some of the photos in that slide deck. Our IHS partners in this. It's really been such a tremendous, really a privilege to work alongside IHS and others involved in the COVID response, and to be part of this family of really creative, compassionate, committed people who are working incredibly hard on this response. Obviously, CDC has been instrumental in developing a lot of these materials, and the Center of Faculty and Staff. And then the next slide, I think, lists some of the key contacts for the community-based health programs that we touched on today. And these individuals are panelists on this call. I want to make sure that we have time to take questions, and I see that a number have come in through the Q&A. So I will just ask if people do have questions, the best way to get those to us is through the Q&A box on Zoom. And I think we can just start from the top. And if any of the panelists want to jump in on these, please just do that. So the first question is about the analysis of obesity as a strong risk factor, especially in young people. And I think that that is something that is important to note. That does seem to be among young people who do end up having more severe disease. That is a very compelling and important risk factor that has been identified, and one that I think we can make sure to emphasize in our messaging for people, to know the importance of that social distancing, because it may not be sort of an underlying condition like heart disease that we're talking about, or diabetes that we're talking about. We have to understand all of the different risk factors that are putting people at greater risk. There's a question here about if you have an N95 mask at home that you purchased before COVID-19, can you still use those or not? And absolutely, you can use whatever masks you have your hands on to protect yourselves and to protect other people in case you're asymptomatically infected when you're out in public spaces. There's a comment here about rumors for after somebody has passed away from COVID-19, and commenting about remains being cremated and disposed without families having opportunities for traditional or proper burials. I have not heard of that, and I certainly know in many settings that that's not occurring. There are special precautions, as you can imagine, that do have to take place, not only to make sure that if that was the cause of death, that the deceased is properly handled so that that doesn't pose any risk of infection, but also we understand that large gatherings of people for funerals or wakes are potentially ways that the virus can spread to infect even more people. And so I think it is a very challenging and difficult topic. I think we do know that it's obviously incredibly important to honor and respect the deceased, and to do this in a way that is aligned with Indigenous values. And so while I cannot speak to the specific rumors that are addressed there, other than to say that I don't believe that that's the case. And I'm certainly aware of situations where people have been allowed to have a traditional and proper burial for their loved ones. There's another question here about depending on the region or tribe that a CHR serves, people can find themselves in different roles and may need to have appropriate use for PPE. And so I think this is critically important, and we do need to make sure that people know how to properly don and doff, or put on and remove personal protective equipment to keep themselves safe when they're in clinical settings. And there are a number of different training videos that have been produced by various different groups. And I think within different IHS regions or with different tribes, there are opportunities for training on PPE specific to COVID-19. Much of this applies to other communicable disease outbreaks as well. And I just want to check if there's anybody on the panel who wants to comment further on that.
Hi, Laura, it's Michelle. And I think that's an important question, and I would just encourage that participant to reach across in their area out to their public health nursing, contact their environmental health point of contact at their particular healthcare center for that additional training. I don't know if Tina has something to add to that.
Okay, well, if Tina, if you want to chime in, feel free to do so. But I think, thanks, Michelle. I think that's great guidance. There's a question about the availability of the materials, and those should be available, and they can be used with attribution. Yes. There's a comment here about how have families in the more rural eastern agencies been provided with water and or sanitizer so they can practice good hand hygiene. I think this is an important point about some of the outreach that's being done, is that we know that there are some heavy areas of transmission right now that have water scarcity, and so it is really important to try and make sure. I think this is something that IHS, as well as some of the grassroots organizations that are supporting this response, are trying to work to make sure that people do have access to the things that they need: disinfectants, hand sanitizer, and where water is scarce, hand washing stations that can be used to slow the spread.
Hey, Laura, there's a couple questions I might be able to address on here.
Great.
Okay, so there's a question on here about how are communities addressing the need for recovery centers or places to isolate in when there are housing or facility shortages on reservations. And then kind of a related question around the community center in Chinle and the protocol for using it. And so I'm gonna kind of answer those together for everything that, well, I'll speak to kind of how it's been working on Navajo, recognizing that I'm not the expert on this, but that the Navajo Nation has a incident management team that's working with Indian Health Service and FEMA and the states and, you know, many entities in the responding to this emergency situation. And one of the things that, and the National Guard, so FEMA and National Guard are working with Navajo Nation to and coordinating with IHS to identify locations in the community and bringing in equipment, and then assisting with identifying staffing to create, and they're doing this all over the country, but to create centers for different levels of care that aren't currently available. And so some of those levels of care, one is like the kind of the, is like people that don't need medical care but need a safe place to isolate. Because, you know, we all know that there's, you know, many places in Indian country where a lot of people live in a small house, and that makes it really difficult to stay separate if one person's infected and the others aren't yet. So, so that level of place to isolate, then also what they call alternate care sites for people that need medical care to increase the capacity of the healthcare facilities. And so those are in process here. It takes time to establish those. So in lots of places in the country, I think in New York and in Washington, where, you know, things happen sooner, like they, you know, got extra facilities built. On Navajo, that's still in process. And then I would imagine that those kind of same responses will happen in different parts of Indian country, depending on what happens. And so that those facilities take time to put into operation. And so like on Navajo, none of the centers are operational yet. So that means there can be a window of time where it's very difficult to know what to say to patients because you don't have a lot of alternatives. You know, and Gallup worked with the state and others to set up, work with a hotel for a place for homeless to stay and isolate. But it's going to be very dependent on your location and who your partners are. I think, Laura, there was also a question about, I know we just have a couple minutes, a question about contact tracing and, you know, strategies to address contact tracing. So I don't know if you want to mention just, you know, having a specially designed platform, those opportunities out there. Maybe I guess say just to let people know that there are platforms out there that can help with contact tracing, and that Indian Health Service is exploring some options right now, like with some platforms to be able to enter data and to manage cases on a larger scale. That is, and so that's something that hopefully is coming. And then the question of like building up the capacity for contact tracing, like I think that in many areas they're going to have to look at training people that don't normally do public health and CHR work or epi response work to assist with the effort that would need to be part of surge planning everywhere.
Thanks, Jill. There's another question here about behavioral health resources and mitigation efforts, and I think absolutely there are there's a lot of work that's being done on this. Every location should have a hotline number that they can call for people with specific mental health needs. But in terms of other behavioral health resources, I encourage you to check the IHS resources page, as well as the Center for American Indian Health COVID materials page, which contains a number of tips for behavioral health related items. And if you have other suggestions for materials that you think would be helpful, we're definitely welcome that input and that those types of requests. There's a question about sufficient infrastructure to support telehealth. That I think is many rural places struggle with having sufficient infrastructure in terms of connectivity to allow for telehealth, but it is a strategy that's being more widely deployed, and I think is an important way to be able to, for us to continue to, especially everybody who's on this call, for us to be able to continue to meet the needs of the community and the health needs of the community without necessarily having people travel into settings that put them at risk for possible transmission. So I think we would like that infrastructure to be better across Navajo Nation as well as across rural parts of America. And I think that will, it is being addressed by incident command centers in various different places. Educational materials about how to treat yourself at home. So that again is available currently on the IHS resources webpage, as well as the Center for American Indian Health website, that have some general guidance about just symptomatic relief and how to monitor yourself for symptoms and when you would need to call in for additional care. The CDC website also has a self-checker app that you can use as well for self-care at home. There's another question here about the numbers on Navajo Nation and how they are for the state of New Mexico. Those jurisdictions are communicating, so those numbers should be aligned. As you know, there are many, Navajo Nation obviously spans parts of Utah, Colorado, and New Mexico, so the Navajo Nation numbers and New Mexico numbers should align for those residents of New Mexico. And I know there are a couple questions here about resources for self-care providers. Those are things that we're working on. I don't know if somebody on the comms team can comment. I think some of them may be posted, others are in the pipeline. Keep that IHS resources page in your bookmarks, and you'll be able to see those come through. I know that we have a handful more questions here, but that we're also at the top of the hour. And so I want to be respectful of people's time. And I think what we'll do is there is an FAQ document that we'll develop on this. And for the questions that we're not able to answer live, then we'll make sure to address those in a written FAQ document that we can circulate to all of the participants. So with that, I really want to wrap up and thank everybody for being with us today. And more importantly, to thank you for all of the work that you're doing, your trusted voices in the communities where you serve, and your incredibly important to this pandemic response in terms of the work you're doing around social mobilization and distribution of health information to communities in culturally appropriate manners, as well as assisting with contact tracing and other efforts. So we thank you all for joining us, and we look forward to speaking again next week about some additional aspects of community health work in the pandemic response.